and violations of the Affordable Care Act. This webinar is the last in our State of Coverage series, which examined health.
The broadcast is now starting. All attendees are in listen-only mode.
Hi, everyone. Welcome to the webinar, State of Breastfeeding Coverage, Health Plan Violations of the Affordable Care Act. This webinar is the last in our State of Coverage series, which examined health care plan violations of the ACA. For more information or to access other webinars in this series, please visit www.nwlc.org/State of Coverage webinars. For today's webinar, all lines will be on mute. If you have a clarification question or you're having technical difficulties, please use the chat function to send your question to all presenters, and our speakers will make sure to address it. Throughout the webinar, please feel free to send us questions through the question and answer function on the webinar. We'll be taking questions at the end of our presentations. And just so you all are aware, we'll be sharing this webinar recording and the slides within the next few days. Also, just a brief disclaimer that this webinar is intended for advocates and those interested in the topic and not intended for press purposes. So with that, we will get started. I'm thrilled everyone can join us today to talk about the state of breastfeeding coverage, health plan violations of the Affordable Care Act. I want to take a moment to welcome my co-presenter for this webinar, Beverly Curtis from the National Breastfeeding Center.
Thank you, Anna.
Okay, I'm just going to get my slides ready. One moment. Oops, there we go. Okay, great. So what will we cover today? We will start by reviewing our recent report on the state of breastfeeding coverage, and we'll review stories we've gathered from our national hotline, CoverHer. I'd then like to turn the mic over to Beverly to talk more about breastfeeding coverage, and we will save plenty of time for questions and answers. I'd like to start at the beginning and talk briefly about the Affordable Care Act. This historic law is a real game changer for women's health. Before the law, women in the individual market were charged more for health insurance than men, a practice called gender rating. Excuse me, they were often denied coverage for pre-existing conditions, such as a history of domestic violence or a prior pregnancy. And when they managed to get health coverage in the individual market, it didn't cover things like maternity care or mental health treatment. And the ACA ended all of that. The ACA ends discriminatory insurance practices and ensures that the coverage women get actually includes the services that women need. The ACA also makes an historic investment in prevention. It requires coverage of a range of preventive services for women, like well woman care and birth control. And today we'll be taking a deep dive into the ACA's coverage of breastfeeding support and supplies. Let's talk about what the law requires. The ACA's breastfeeding benefits are part of the law's coverage of preventive health services. The IOM recommended 8 preventive services for women, and breastfeeding is one of those 8 services. We know that the law requires coverage of breastfeeding support and supplies for the duration of breastfeeding at no cost sharing. This means it must include comprehensive lactation support and the cost of renting or purchasing equipment with no copay, no deductible, or co-insurance. And we know that this requirement applies in conjunction with each birth. Now to the question of where this requirement applies. Most employer plans that are ungrandfathered are required to provide these services. I'm not going to spend too much time talking about grandfathering and grandfathered status, but it has to do whether or not this requirement applies to your plan. We have a toolkit that really walks through grandfathering and has a script to find out whether or not a person's insurance plan is grandfathered or ungrandfathered. So you can always go to that link for more information. Eventually, all plans will lose grandfathered status and will be required to provide these services. Qualified health plans that are sold in the individual marketplace are required to provide breastfeeding support and supplies. And Medicaid enrollees who are newly eligible as part of the state's decision to adopt the ACA's Medicaid expansion also get these services. And last year, as part of the National Defense Authorization Act, TRICARE is now required to provide coverage for breastfeeding support and supplies. It's important to note that the ACA doesn't apply to TRICARE, but that TRICARE will now provide these services through the National Defense Authorization Act, which passed very recently. What you'll note here is that breastfeeding support and supplies is not required to be covered as part of traditional Medicaid programs, and that coverage will vary state by state. but the ACA does not reach traditional Medicaid programs for preventive services. Let's talk a bit about where to get these services. Insurance plans must create a network of providers for enrollees to access covered benefits. And in the case of preventive services, federal guidance says that if a plan does not have a network to provide a preventive service, they must allow enrollees to go out of network at no cost sharing. So in the case of lactation counseling, if the plan does not have a network to provide this service, women must be able to go out of network at no cost sharing. What else does the ACA say? Plans can use reasonable medical management techniques to determine the frequency, method, treatment, or setting of a preventive service. But there are some rules about this. For example, plans can require women to rent a breast pump versus purchase a breast pump or vice versa. But plans cannot impose limits on coverage that conflict with federal regulation or guidance. So for example, plans cannot limit breast pump coverage to 6 months after delivery because the requirement of coverage is for the duration of breastfeeding, which of course could be longer than 6 months. What else can plans do? Unfortunately, plans can provide coverage of a manual pump and still comply with the law. In other words, the plan gets to decide what kind of breast pump they will cover. We think this is totally insufficient, and we have told the Department of Health and Human Services, the Department of Labor, and the Treasury Department that we think this policy undermines the intent of the ACA, and we would like them to re-examine this standard, but we will talk more about this later. So let's turn to the findings in our report. We looked at qualified health plan documents, sometimes called certificates of coverage or evidence of coverage documents in 15 states in 2014 and 2015. And we collected stories from our hotline from women who have tried to get breastfeeding benefits. The hotline is called CoverHer. And what did we find? Well, we found some significant violations of the law. Our findings confirm what we hear on the hotline and vice versa. And we also see the same problems in employer-based plans. Let's first talk about the restriction and limitations on breastfeeding support and supplies that violate the ACA. Our research found unallowable limits on breast pumps. And we have a list of examples right here. All of these conflict with the ACA's requirement to provide coverage for the duration of breastfeeding. I don't need to tell this group why this matters because, of course, you are the experts, but many women need access to breast pumps to build and maintain their milk supply for a variety of reasons. But these restrictions are problematic, and they violate the law. Our research also uncovered some pervasive problems with coverage of lactation counseling. Very often, plan documents did not mention lactation counseling at all. In plans that did talk about it, we found plans that would only cover lactation counseling in the hospital on an inpatient basis as part of a woman's maternity stay. And we also found plans that limit coverage to a short window in the postpartum period, such as 2 months after delivery. Finally, we found plans that limited coverage to a single visit, which we think is insufficient. And all of these restrictions are clear violations of the ACA's requirement to provide coverage for the duration of breastfeeding. Another trend that we found is that plans do not have in-network providers and are not following federal rules. We could talk for an hour about the network problems, but when women contact us about their breastfeeding coverage, they often say that their insurance plan either doesn't cover lactation counseling or they do not have any providers in network. Furthermore, plans are not following rules about getting services out of network. As you recall, federal guidance is very clear. If there is no network to get a preventive service, and breastfeeding is recognized as a preventive service, then the plan must allow the woman to get services out of network at no cost sharing. We know from our hotline calls that many plans are not following this rule, or they're following it inconsistently after a series of denials and appeals. So let's turn to some stories about that illustrate why this matters. Again, I don't need to tell this group why this is so important. We heard from a woman in Virginia who called her insurance company to find a lactation consultant, and the plan did not have anyone in network. So she went out of network and paid the full cost up front. And what's particularly troubling to me about this story is that the cost is really a barrier. She was worried that not only would she not be reimbursed for the visits that she already had, and even though she was still having problems, she was worried about whether the plan would reimburse subsequent visits. This is the opposite of what the ACA intended, which was to remove cost as a barrier. We also heard from a woman in the DC metro region who was referred to La Leche League as her provider network. Of course, La Leche League is a valuable resource, but it is not an insurance network. Her insurance company even gave her the name of the women who run the meeting, who of course were not contracted with the insurance company to provide services. In addition to outright violations of the ACA, plans impose major barriers to coverage. For example, some plans require prior authorization for either a breast pump, lactation counseling, or both. In the case of breast pumps, we've heard that prior authorization delays getting a pump for several weeks. Women might need to pump right away if they're having problems, and this prior authorization is a barrier to timely access. In terms of lactation counseling, women report paying the full cost up front and then going through a month-long series of denials and appeals trying to get reimbursed. This is a real barrier to the benefits because women aren't sure if they'll ever be reimbursed, which is really inexcusable. So let's talk about federal guidance and manual pumps. Back in the fall, the Department of Health and Human Services came out with a fact sheet that said it's up to the insurance company to decide what kind of pump they will cover. What this means is that they think insurance companies can only cover a manual pump and comply with the law. We think this standard is unreasonable and insufficient. And again, as you as the experts know, that women will need access to electric or hospital-grade pumps for various reasons. Where do we go from here? We have recommendations for insurance companies, state and federal regulators, and the federal agencies that implement the law. For insurance companies, we feel that insurance companies must comply with the ACA, and that coverage documents must comply with federal regulation and guidance. Plans must, at a minimum, establish a network of lactation providers so women can actually get these services. As plans build this network, they must allow women to obtain services from out-of-network providers at no cost sharing as required by law. And plans must remove all administrative barriers to getting lactation support and breast pumps. We recommend that state and federal regulators step up enforcement of the law, and we want a greater focus on compliance about coverage violations, particularly for women who are not able to get reimbursed for going out of network. We think state regulators should inform women about the law and its coverage requirements so that more women know they are entitled to these benefits. And finally, more needs to be done to publicize the appeals process so women know their rights. We want the agencies that implement this benefit, which is the Department of Health and Human Services, Department of Labor, and Treasury, to revisit current guidance. Coverage really should be aligned with expert recommendations and best practices, and this means that the department should re-examine coverage of only a manual pump. And as they do this, the department should engage stakeholders, breastfeeding experts, the medical community, advocates, and insurance companies to develop new federal standards for breastfeeding coverage that helps women breastfeed successfully. Thank you for your time and attention. Please continue to submit questions. We will do those at the end. I'd now like to again welcome Beverly Curtis from the National Breastfeeding Center. Beverly, thanks for joining us, and I'm turning it over to you.
Thank you, Anna. That was a great review of what has been known so far with the law and what we're experiencing. I'd like to take a slightly deeper dive for a few moments and just talk about some of the items that we've seen with the National Breastfeeding Center, and then move to some of the discussion afterwards. Can you all see my screen now?
Yes, I can.
All right, thank you. All right, so what we're looking at then for today, I thought I would just review a little bit. Obviously, we have reviewed the law already, and then we want to talk about some of the commercial insurers' perspective on the ACA, as well as some of the requirements that the payers or the commercial insurers are required to provide when they are writing their policies and things that are in the policies. As we all know, I'm just going to adjust my screen a little bit here. The Affordable Care Act primarily covers the commercial insurance contracts. And as Anna already covered, it's not mandatory for Medicaid. and is not, it does not apply to the military. The military, as Anna said, has their own coverage through the National Defense Authorization Act. So they are not required to follow the ACA guidelines. One insurer that sort of jumped on the bandwagon pretty quickly after the ACA was passed was Aetna. And we were thrilled in the lactation community to see that they opened their networks to international board certified lactation consultants. They had identified a specific billing code to use for lactation consultants. They covered pump purchase costs when obtained through their durable medical equipment providers. And they covered hospital-grade rental pumps for medical necessity. So we found that this was a great beginning for insurers, and there was a hope that other payers would follow suit. Their policies for Aetna also, they publish their policies on the provider site, and so providers could go in their special area on the site and see what was covered, and they educated their members about their coverage. So we were very thrilled to see what Aetna began and thought other insurers would follow. Here's just what they published and marketed to their members in terms of their lactation and breastfeeding services. And as you can see here, they have listed a standard electric pump within 60 days of birth, or once every 3 years, et cetera, et cetera. So they did have some limitations on what they provided, and Anna's already gone through what the requirements of the law are, and we can see that not all payers match that level of what the law requires, and that's the caveat. That's the difficulty, is that every payer can interpret this law according to how they see fit, in a sense, because there are not concrete identifiers as to what they must cover. And it's a little ambiguous, and some payers have chosen to cover what they feel may be minimum standards or what they can cover according to the economics of their decision makers. And so they may cover a minimal amount in what we see as a minimal amount for how we would like the law to be interpreted. I have here the ugly model, which would be the minimum coverage. The payers comply with the bare minimum in their interpretation of the law. They may cover hand pumps only, limited promotion of the coverage to members, no guidance on coding, which is a billing issue, a bundled payment for in-network providers, and no way to get around that. So if it's a specific service offered for those that are in network, say in an inpatient setting, there's no payment set aside for lactation-specific services. Undefined and usually unpublished policies. So it's very hard for the consumer and even providers to find the policy to know what is covered and what is not. As we move forward, we'll talk a little bit about the scorecard that the National Breastfeeding Center has, and the Women's Law Center as well did a review of policies, of payer policies, and we see that some comply with the law very nicely and others do not. The scorecard National Breastfeeding Center put out last fall did review many policies and looked at if they included lactation consultant services, pumps, breastfeeding classes, all those sorts of things that the law describes as necessary for coverage. And as we move into looking at the lactation provider, then we get into some more areas of difficulty. Commercial insurers usually have a network of providers, and these providers are those that are credentialed and contracted per their certain rules and regulations that they must follow. Most providers who are admitted into a payer network, so a specific insurance company who has providers in their network, are recognized as licensed providers. And this is the key word there. They're looking for licensed providers. So licensed providers include those that have licenses to practice. And so that would be MDs, DOs, nurse practitioners, physician's assistants, generally are those that are recognized as licensed providers. Some payers include dietitians in that list as well, and possibly some other professionals. But lactation consultants are not licensed, so they're not recognized as licensed providers and therefore not considered providers by most insurers. That's why it was so amazing that Aetna took on a non-licensed provider in recognition of lactation care providers. The other thing that payers need to do is they need to credential. So the credentialing process is actually a standard of the industry. It's required by all payers, and those requirements are set by the National Committee on Quality Assurance. The credentialing really does protect the consumer so that you know that the provider that you have for a specific service has the qualifications necessary to provide that service, meets certain criteria related to professional competence and conduct, and has the relevant training, the licensure, the certification, or professional registration to practice in a healthcare environment and field, and they have an academic background to do such. So the credentialing process is an important process for consumer protection. Insurers are responsible for credentialing all independent practitioners with whom they contract or employ, and that includes this list of physicians, dentists, chiropractors, podiatrists, and others. However, it's difficult to credential a subset of providers who don't meet that same standard or who don't fit in that box of licensure. So non-physician practitioners undergo a credentialing process much like physicians, and the differences lie in the requirements and therefore in the verification of the data that they look for. Lactation consultants are not covered in these guidelines that are set out by the stakeholder organizations who set these standards, and therefore usually they're not covered by the payers, and that really creates a difficulty when trying to access care. So payers are required to evaluate the qualifications of the provider, ensure that each practitioner meets certain criteria related to professional competence and conduct, are responsible for credentialing all independent practitioners with whom they contract. They must confirm that the provider is in good standing with state and federal regulatory bodies and ensure that each provider has been reviewed and approved by an accrediting body. This explains why some insurers have chosen to credential IBCLCs, but possibly not other types of LCs, and when many have decided not to recognize non-licensed providers at all. Now, when we talk about licensure, so that's
Beverly, are you still there? I don't hear you. So it sounds like we lost Beverly. I don't know what happened. I hope people can still hear me. This is Anna Benyo at the National Women's Law Center. I presented earlier. I'm going to give Beverly a quick email, and I'm also going to see if she can hop back on. But I just want to I'll take this time while she's getting back onto the webinar to take a few questions because we've actually had a lot of them coming in. So let's start with some questions. So someone asks, can employers limit how long they will provide coverage or cap the amount that they will cover? It's a really good question. Employers cannot limit how long they will provide this coverage or cap the amount they will cover. So no, the coverage is provided through through the insurance. And as I mentioned in my presentation, the coverage is provided for the duration of breastfeeding, and they aren't allowed to cap that for a certain amount. Now, they can use reasonable medical management techniques. So that might mean limiting coverage to 6 visits, for example. We don't really have a definition on the frequency of how many visits would be considered reasonable under the requirement to provide this coverage. We think at the National Women's Law Center that 1 visit is insufficient, so we consider that to be a violation of the law. But we don't really have a line from the federal government that says you have to provide coverage for 6 visits or 8 visits or 2 visits. We don't have that information. That's something that we'll be asking the federal government for. And let's check quickly to see if Beverly is back with us.
I am. I'm back on the line. Can you hear me?
Great. I can.
Yes. Okay. We lost power here for some reason. So are you able to see my slides?
Yes.
All right. So we were talking about that licensure is the acceptable guarantee for the public and insurers of a professional with a minimum standard of competency to practice in the healthcare arena. As we look at licensure, we want to also identify that it is the manner in which third-person payers verify and recognize and reimburse for healthcare services. So understanding that that lactation consultants are currently unlicensed, it's very hard for the payers to bring them into the fold of being a provider in their network or even outside of their network. So that is the challenge for any lactation care professional currently providing lactation services for mothers. Here we have activities of licensure within the United States, and you'll see that these are activities for licensure for International Board Certified Lactation Consultants. I'm sorry I don't have the data for other groups seeking licensure, but this is just one example of how you can see that there's approximately 35 states that have some action regarding licensure for an IBCLC. And you'll see the blue stars there's an operating committee that is addressing the licensure issue in that state. The green star is that licensure or legislation may have been introduced at one point. And we're looking for the orange stars that would indicate that licensure has been enacted. And we're not seeing many of those. But there is motion and activity to begin this process, and it is a state-by-state process to accomplish licensure for lactation care professionals. If you are interested in pursuing that, I would suggest that you contact your state breastfeeding coalition or the United States Lactation Consultant Association or the organization in which you are credentialed or certified, and see what activity that organization may be doing to pursue licensure in your state. Once your insurer or your payer credentials you and identifies you as a provider, if that would occur, and it does occur at times with some payers, and you've credentialed successfully, then you're considered in the network. And as you are in the network, then you're contracted, and you would receive, you must sign a contract identifying you as a participating provider. There's some rules regarding that, and you must accept the insurance company's payment as payment in full. So if you're billing that company and they reimburse you a specific amount, you cannot bill above that to the patient. It also means that the lactation, I'm sorry, I just said that you cannot bill the patient for the differences between the typical rate and the contracted rate, and the rates are different in different regions of the country. Can a lactation consultant or a lactation care professional join any network? Again, it's very limited. And because there is no licensure currently for lactation care professionals, and many are not MDs, DOs, dentists, advanced practice registered nurses, or PAs, the network may not accept you at all. And Aetna is one of the few insurers crediting and contracting lactation consultants, but they will do so only right now for those with the IBCLC designation. Basically, everything is based on economics, and the consumer and the employers pay insurers to provide the benefits that we're discussing, and those benefits are regulated by a number of factors, some mandatory by the ACA, and then also medical efficiency and demand in the area. And you have to remember that most insurers are for-profit businesses, and so they're making decisions and setting policy for their shareholders that they satisfy them and for what is economically sound for their business. So as I've talked to mothers, I've heard mothers and also others working in the field be told by their insurers that to provide a hospital-grade pump or to provide an electric pump is just not fiscally sound for their business, and they felt that it would be a money loser. So, you know, these are some of the things that that have been reported back to the National Breastfeeding Center. And you know, they want to maximize their profit, and they have to keep their costs as low as possible by paying as little as possible for as few things as possible. What seems to be missed in this mix of decision-making is that when, of course, breast milk is provided to an infant who may be medically compromised, that there's millions of dollars saved by that infant receiving breast milk. And the benefits to the mother are great when she has protection from premenopausal breast cancer and ovarian cancer and possible cardiovascular disease. So there's many, many benefits of providing the breast milk, and the cost is minimal of a breast pump compared to the repercussions of the infant or the mother not being able to breastfeed or the infant not receiving breast milk. And so from the payer perspective, they need to look a little bit bigger and wider and, you know, expand their umbrella some to see the benefits of breastfeeding as a public health initiative rather than a fiscal decision only. Some patients assume that the Affordable Care Act will pay for every single visit or every single service that they receive. And again, because it's so individually bound by the patient's own payer and the policy that they are under, every patient should be able to identify what those services may be and what their payer does cover. So as Anna so eloquently stated earlier, that there are transgressions in the Affordable Care Act, and so not every mother and woman is receiving these benefits as she should. So every patient's benefit package is different. Lactation consultants should only submit to the plans in which they participate. And right now, because of the lactation consultant professional not being entered into the fold of in-network providers, it may well be that the patient is told to pay up front and then provide a super bill for submission. This becomes very difficult for the patient and actually then means that there may be cost sharing that is then not reimbursed to the patient. So it's a very difficult position the patient's put in now, as well as the lactation consultant or the lactation care provider. Payers need education and assistance. So every time a patient or a lactation care provider becomes aware that there's a breach in the system in some way, clarification is needed and evidence needs to be provided to the payer to identify what the problem is and how their policies could be more standardized and come more in alignment with what the Affordable Care Act requires. There needs to be guidance on coverage criteria, types of providers, how to bill and code for these services, what equipment is covered, and an adoption of a comprehensive policy. The National Breastfeeding Center and the United States Breastfeeding Committee actually produced a model policy for payers so that they could look at a policy that may be more in alignment with the Affordable Care Act. And you can access that policy if you're not aware of it with this link to the United States Breastfeeding Committee or on the National Breastfeeding Center site. And then the scorecard that I referred to earlier is on the National Breastfeeding Center site. We produce one every year, so this is last year's coming out at the end of November of last year, and we should have another one that we're producing this year. But what it does is it looks at the insurer's policies and the payer policies and rates them according to actually the model policy to see if there's coverage for these services that we believe is in the spirit of the Affordable Care Act. Working with insurance companies is not easy. As the National Women's Law Center has identified, there's many mothers who've spent hours and hours trying to receive coverage for these benefits while they're trying to nurse a newborn. Utilize your associations to find this valuable information. So go to your state insurance commission, go to your state breastfeeding coalition, and find out how you might be able to help to make these services more accessible to women. Utilize your payer websites and Google to find the policies that you're looking for. And then help people you know who are patients, help people you know who are your friends, and help lactation care providers to really identify and direct the payers in areas where you find that there needs to be changes. Encourage if you're working with mothers to find and determine what their benefits are and how to go about submitting charges and also changes to their benefits and network. This is an area that is of deep concern for maternal child health, and I thank you for your interest today, and I also thank the National Women's Law Center for a superb job in bringing this to the national level and to the attention of those that can help change the law and make benefits better for women. Anna?
Thanks, Beverly. That's really great to hear. I feel like you covered a lot of areas that are of importance to our audience. I'm getting lots of questions. I'm going to continue to allow those questions to queue up. We have about 20 minutes left, and we have dozens and dozens of questions. I will do my best to put them together in different groups, and Beverly, sometimes I'm going to throw it to you to answer some of the questions related to your presentation.
Okay.
There are several questions about coverage of a breast pump prior to the baby being born. We are very concerned about this. There is nothing in the regulation or the guidance that says women have to wait until the baby's born or that they can't get a breast pump earlier. The guidance specifically and the IOM recommendation specifically says that the coverage is in conjunction with each birth. Unfortunately, a lot of insurance plans have interpreted this to mean they will not provide coverage until after the baby's born. Of course, we find this problematic because some women will know that they need a pump right away, potentially if they've had subsequent children. Obviously, you don't want to be scrambling to do that, and with some of the issues I talked about earlier in terms of prior authorization and some of those other barriers, it's important that this be timely. So that's something that we're working on. We've brought that to the attention of the federal government and other implementing agencies, and let them know that it's a barrier and that women are not able to get this, that many women report they're not able to get a breast pump prior to delivery. So I guess the short answer is we think that the federal government should come out and clarify that you can get this before the baby's born. Right now, insurance companies are not doing that, but there's nothing written anywhere that says they absolutely have to provide coverage of a breast pump before the baby's born. So, there are several questions that are just simple questions like, how does a lactation consultant get part of a network? Beverly, do you want to tackle that?
Well, I think we did address some of that when we were talking about lactation consultants. The best way is to actually contact, and you need to contact every payer in your area who you would like to be credentialed with and find out what their requirements are. The other part of that is that you do need a provider identification number called an NPI number, so you should register for that, and you can simply do that on the NPI website. So that would be your first step, but then you need to go through the credentialing process as the payer requires. And so it is literally, there isn't just one stop where you can go to some place and register and you're in with everybody. It is every single payer that you would need to approach, and then they have their requirements and forms to fill out, that sort of thing. So that would be what you would need to do. Sometimes this takes a while to achieve. When Aetna first opened opened the box, so to speak, opened the door and allowed lactation consultants to be providers, they ended up being flooded with applications. And so they took those that they could process to begin with, and now there seems to be quite a lag time. The other issue is, though, is that many payers argue that they have providers and that this service should be covered and provided by those that are already in network, which are their MDs, their DOs, their NPs, and their PAs. And they haven't identified that there is specific training for lactation care that does require certification, and so they haven't recognized the IBCLC or the CLC or others as having specific training in lactation care. And so their argument is our MDs can provide this service. And unfortunately, as we find, there are some MDs who are trained in breastfeeding and lactation services, but many who do not provide that service. And so then the mother is left with going from the OB to the pediatrician to the family practice doc, to back and forth, trying to find that help. And ultimately, as Anna mentioned, being referred to La Leche League as a provider, there are many services that La Leche League does provide to mothers in terms of mother-to-mother support groups, which are invaluable for breastfeeding care. However, when mothers need more advanced care, their insurers and payers should be able to provide advanced care of an individual who can provide breastfeeding medicine or lactation consultant services to her.
Thanks, Beverly. We have a question here about who the regulators of the ACA is in the states, and it's a great question. One of the things we've been doing in terms of the follow-up work from our report and the findings is work directly with insurance commissioners who are the regulators for health insurance in the states. And insurance commissioners certify qualified health plans often that are sold in the marketplaces, and they are familiar with the coverage requirements. And so if there are concerns, and we often advise women to follow up with insurance commissioners in terms of their ability to seek an external appeal for coverage denials, it's a great resource. We are also, in terms of next steps in advocacy, we think that's a great place to bring your concerns, to let them know that you are having trouble becoming part of the network, or that your clients are caught up in this maze of being out of network and not getting services at no cost sharing. The insurance commissioner and the departments of insurance are the best places to go to do advocacy, and then for them to hear the complaints of individual women.
And I have known that there are some state insurance commissioners who are very open to these discussions, very welcoming of hearing the complaints and looking towards changing some of the state of the breastfeeding coverage within their own state. So some have actually referred to the model policy in their dialogue with individual payers, so that they have a reference for what a specific model might be. So if you're going that direction, it would be good to reference that or the material from the National Women's Law Center. Take that as your help when you go to the State Insurance Commission. Other questions, Anna?
Hi, everyone. This is Caitlin with the National Women's Law Center. It would appear that Anna has lost her connection. Beverly?
Yes.
Are you still on the line?
I certainly am.
All right. So we apologize for having some technical difficulties today. I'm sure Anna is calling back in as we speak. Beverly, I know Anna just sent a message. She was hoping you could talk a little bit more about licensure because there are a couple of questions about that. So I think there might be some clarification needed there.
All right. Do you want to send me those questions or read those questions for me?
Sure. Hold on just a second. And I apologize to the audience. It might look a little weird on your end while I pull up some of these questions. Let me see. Again, my apologies for that. Okay. I apologize. You have a lot of questions here. Some questions. There's some questions about whether or not an RN would be considered a provider. And I think there's also some questions just about generally going through that one more time, maybe in a little bit more detail.
In terms of RNs being providers, while RNs do have licenses, there's a state license for an RN. In terms of reimbursement, that reimbursement is still poor generally as compared to what MDs and DOs, PAs, and NPs can be reimbursed. So while your RN license is helpful, you are still not considered a licensed provider by the payer. So there's just a difference in that level of responsibility that the payer perceives. So in terms of being a licensed provider, they're looking more for the MD, DO, PA, and NP. In terms of licensure for lactation consultants, this is a huge area of work that has been addressed by the United States Lactation Consultant Association for the IBCLC. If you are an independently certified CLC, I would suggest that you go to your parent organization and inquire about the work they've done for licensure in your state. The US LCA has a significant amount of work that they've done in this area, and I'll just refer you to their website, and they have quite a substantial brochure there and information that you can access, and that would be a much more efficient way than for me to work through those steps of pursuing licensure in your state. I would just suggest, though, that you collaborate with the other individuals in your state, with your state breastfeeding coalitions, with your regional coalitions, state health department and your state insurance commissioners and others to work together. It really is a work of collaboration to bring this about, and an important step is to include all those stakeholders in your state.
Great,
Other
thanks.
Questions? Mm-hmm.
Yes, I'm back on. I'm sorry, everyone. We're having lots of technical difficulties today, and my phone just totally shut me off. So I want to get to more questions, so I'm going to try to go through these quickly. We have a lot in the queue. I just want to reiterate that the best way to ask questions is through the Q&A rather than raising your hand. And I just also want to reiterate that we will send around this webinar, the recording, slides, supporting documents, and of course our contact information for follow-up and questions. If we don't get to your question today, I'm happy to talk to you at another time. So let's see. The next set of questions are about Medicaid. So let's just touch on that quickly. One question is about how to know if your state has adopted the Medicaid expansion. Someone has asked that question from Texas. Texas has not adopted the Medicaid expansion. I'm happy to send around a list in the materials for this webinar of a list of states that have adopted the Medicaid expansion. There are also resources from CMS and from Kaiser Family Foundation that are a little out of date, but that talk about which states are covering some kind of breastfeeding coverage, whether that's a pump or a little bit of counseling. Again, they're not the ACA benefits. This is for traditional Medicaid programs, but we do have some information on breastfeeding coverage in traditional Medicaid if there is that coverage in your state. And I will make sure that that is part of the follow-up packet. Let's see. There's an interesting question here about New York and one of the insurance companies requiring a letter from a workplace or school that the mother will be returning to work or school, and that's why they need a pump. That is not something I've heard of before. Thank you for submitting that, and that would not be allowed under the ACA's coverage. There doesn't need to be a medical reason or medical necessity or workplace reason to get access to a breast pump. The coverage is part of your plan if your plan is ungrandfathered, as we talked about. And so I haven't heard something like that, and I'm happy to talk offline with the questioner to provide more information, but that kind of policy would not be allowable under the ACA. There are some questions about, more questions about fighting a violation. We have a toolkit which I've talked about on previous webinars, and many of you are referencing it here, but for those of you who don't know, the National Women's Law Center put out a toolkit about coverage of breastfeeding under the ACA and support and supplies under the ACA, and that toolkit includes a fact sheet and it includes a flow chart for women to use when they talk to their insurance company to find out if they're required to provide these benefits. And it also includes sample letters that they can use upon appeal. So letters including whether or not they got services out of network, and it includes language that specifies the federal guidance that says that they can get these services out of network and what the rules are. So that toolkit is a resource that's up on our website. I'll make sure that it's part of the packet that gets sent around after the webinar, and people should feel free to use it with their clients, to hand it out. And we also work in some cases individually, one-on-one, either through CoverHer.org or through prevention@NWLC.org with women who have particularly tricky cases. Let's see. I'm just checking a few more questions. There continue to be lots of questions about certification and credentialing. I feel like we covered a fair amount of that. I would follow up with Beverly if you have specific questions. I should just note that for the National Women's Law Center, we feel like it's important that insurance companies build this network of providers so that women can get this service in a timely way, in a way that's not too far away from them, and that they can get it at no cost sharing. And so we continue to want pressure being put on the insurance companies and the regulators to make sure that they build this network.
I would add to that, Anna, that as I've been in seminars around the country, I've heard many lactation consultants trying to make a decision whether they would actually participate in a network or whether they'll continue doing what they've been doing in the past, which is charging out of pocket for their services. And I would really urge you, even though we gave a fairly grim picture today of payers and getting in network, that you pursue that, because that is actually what will make the change. That providers need to realize payers need to realize there are lactation providers who need to be in their network, who want to be in their network, and who want to provide these services. And if they're unaware of you, then they may not act at all. So it's very important that we move forward to help provide these services for mothers, because they need the service and they have the benefit, and we need to become the providers as lactation care providers, be the provider for this service. And the payers need to be aware that there is a network out there that they're not accessing.
Absolutely. I'm getting several comments. They're not exactly questions, but comments about how to make this coverage more real for women, and recommendations for advocacy and for follow-up. I think it's fantastic. I certainly agree with commenters that are saying that we should be contacting senators and representatives and others and letting them know that there are these violations and that they need to be addressed. We totally agree. And I just wanted to note all of those great comments because there is definitely a lot of work to be done. I want to recognize the time. We're coming up on 3 o'clock. We still have a great number of you still on the webinar. Thank you for continuing to be with us through our technical difficulties. I have just sent around my contact information, which I realized was not part of the slides. You can reach me at abenyo@nwlc.org, and you can find our resources at nwlc.org/state of coverage. And you will find a link to our reports, and if you scroll through that, you'll find information on our webinars. There are a lot more questions I didn't get to. I apologize for that. I just want to be respectful of everybody's time. We are now hitting 3 o'clock. Thank you so much for joining us today. It's been a pleasure talking about this with you. It's a really exciting new insurance benefit, but clearly there are a lot of things we can do to make it better. So thank you all, and thank you, Beverly.
You're welcome, and thank you all for participating today. And we'll get to your questions and try to answer them in a timely manner.
Absolutely. Bye-bye, everyone.
Bye-bye.